Dr. Mahmoud is with us. It's my pleasure now to be here, and thanks AstraZeneca for giving this session. And it's my pleasure to introduce my professor and our great professor in Alexandria, but now he's in USA. We hope a safe trip back home. He's going to talk to us about SGL2 inhibitors from prevention to treatment. Please, Dr. Mahmoud.
Thank you, Professor Amzaki. Do you hear my voice clearly?
Definitely.
Oh, okay. My presentation today is about sodium glucose transport 2 inhibitors and heart failure from prevention to treatment. I apologize first because some of my slides will be a repetition of slides from Dr. Mark Petrie. Patients worldwide are affected by heart failure, and prevalence is expected to increase with the aging population. Patients with type 2 diabetes have 2.5-fold greater risk of developing heart failure than patients without diabetes. Now, if we go to data from our Egyptian heart failure registry, we see that the prevalence of diabetes in heart failure in patients hospitalized with heart failure was 45%. This is the overall prevalence of diabetes in hospitalized heart failure patients. If we segregate that according to sex, we see that the prevalence is about 41.6% in males and 48% in females, which means that 1 of every 2 women hospitalized with heart failure is diabetic. If we compare that prevalence to European patients who were recruited in the same registry at the same time of our patients, we see that the prevalence of diabetes was only 35% compared to 45% in our registry, which means that diabetes mellitus is quite prevalent in Egyptian patients hospitalized with heart failure. This is the evolution of heart failure. Therapies before 1986, we didn't have therapies of heart failure which reduced mortality. We have just treatments which improved symptoms. Starting from 1987, we had the consensus trial, which invariably significantly reduced mortality in patients with severe heart failure. Then followed the SOLVE treatment and SOLVE prevention trial. Then the beta blockers trial.
دكتور محمود كان ممكن تشيل السماعات عشان الصوت واطي شويه. الصوت واطي شويه.
كده الصوت احسن.
Perfect. Yes. Okay.
Okay. Then followed the beta blockers trials, the MERIT heart failure, CBS2, and Copernicus. Then came the MRA's trial, the RALS trial, and the emphasis. And in 2014 came the landmark trial, the paradigm trial with Secretary Bazartan. It was really a landmark trial. And in 2019, we had the DAPA-HF, DAPA heart failure, which was another landmark trial. Let me present in brief the results of the DAPA-H trial. Well, it was 4,744 patients with and without diabetes mellitus. The inclusion criteria were NIHA class 2 to 4, ejection fraction equal or less than 40%, and NT-proBNP greater than 600 picogram per milliliter. Mean age was 67 years. 68% of patients were NIHA class 2, and mean left ventricular ejection fraction was 31%. 94% were RAS blocker, 96% on beta blocker, and 71% on MRA. And look to the right side of the right panel of the slide. The primary endpoint, cardiovascular death, worsening heart failure event, was reduced, significantly reduced by 26% in the DAPA arm versus placebo. And look to the p-value, it's 4 zeros to the right of the decimal. And number of patients needed to treat was only 21 to reduce cardiovascular death or worsening heart failure. And what was exciting about this trial that the benefits appeared very early. About 28 days, there was significant diversion of the curve, which means that the benefits of the treatment came early. Looking to the endpoints, worsening heart failure event was reduced by 30%, cardiovascular death was reduced by 18%, all-cause mortality was reduced by 17%. These were really stunning results. The primary endpoint was consistent across different parameters like the age, sex, race, geographic region, New York Heart Association class, ejection fraction above or below the median, use of MRAs, type 2 diabetes, ischemic or non-ischemic etiology of heart failure. So the results were consistent across all subgroups. And the quality of life as measured by the Kansas cardiomyopathy, Kansas City cardiomyopathy questionnaire, the quality of life was greatly improved. And the treatment effect was not affected by background therapy. It was on top of established therapies of heart failure like diuretics, MRAs, digoxin, ARNI, and ivabradine. And this is quite important that the benefits of therapy did not differ whether the patients were on angiotensin receptor neprilysin inhibitor or not. That's to say the benefits of dapagliflozin were on top or were added on to the benefits of ARNI. They do not replace ARNI. The benefits are on top of those patients who were receiving ARNI. And look to the NT-proBNP, significant reduction at 8 months of the BNP compared to patients on placebo. And the renal composite outcome. There was reduction of the decline in estimated GFR, more than 50% decline in GFR or end-stage renal disease in the dapagliflozin arm compared to placebo. Now, we discussed the efficacy of the drug, and we have seen that it is quite efficacious. What about the safety, which is a very important issue? Now, the adverse events like volume depletion, renal adverse events, fracture, amputation.
Mahmoud, we cannot hear you, Mahmoud. We cannot hear you.
Adverse events. Do you hear me now? The adverse events. Well, the adverse events were similar between the dapagliflozin arm and the placebo arm. What about patients with type 2 diabetes? This is a very important issue. Is this treatment beneficial in patients with heart failure and reduced ejection fraction who are not diabetic? Do you hear me?
Yes. علي شوي. Okay.
Okay. So the effect of dapagliflozin in patients with diabetes mellitus hemoglobin A1C were significant. But look to the bottom of this slide. There was no effect whatsoever of dapagliflozin or hemoglobin A1C in non-diabetic patients. Well, this is the primary composite outcome. On the left side, diabetic patient, on the right side, non-diabetic patient. The same effect of the primary composite outcome. Concerning worsening heart failure event, the left side is diabetes, on the right panel of the slide, no diabetic patients. It's the same effect. Again, cardiovascular death, and the change in estimated GFR is the same whether the patient are diabetic or non-diabetic. Safety, whether in diabetic patients or no diabetes, I want to stress one point, that the incidence of hypoglycemia was 0 in patients with no diabetes. So I understand this is a major issue for doctors. They are afraid of using SGLT2 inhibitors in non-diabetic patients. But really, believe me, the incidence of hypoglycemia was 0 in non-diabetic patients. So don't be worried about using these useful drugs in non-diabetic patients with heart failure. Concerning the results of the DAPA-HF trial, the dapagliflozin was granted a fast-track approval by the FDA, and this was attributed to the fact that it reduces the risk of cardiovascular death and hospitalization for heart failure in adults with heart failure with reduced ejection fraction. So, sodium glucose transporter inhibitors comprise a new pillar for HFrEF patients. We have the RAS blockers, ACE inhibitors, ARBs, beta blockers, sinus node inhibitors, aldosterone antagonists, ARNI, and last but not least, sodium glucose transporter inhibitors. Let me show you an update version of this slide. Really, we have now 4 pillars for treatment of heart failure with reduced ejection fraction. These are ARNI, beta blocker, MRAs, and sodium glucose transport inhibitors. With use of these 4 modalities of therapies, the cumulative risk reduction in all-cause mortality, if all 4 evidence-based medical therapies are used, is 73%. Relative risk reduction of 73% and absolute risk reduction of 25%. Number of patients needed to treat is 4 patients over 24 months to reduce mortality. These are stunning results. Just 4 patients needed to be treated over 24 months to reduce mortality. So we are now in an exciting era of heart failure treatment. We have treatments which prevent heart failure, as shown in previous cardiovascular outcome trials, the CANVAS program, DECLARE TIMI 58, and EMPA-REG outcome trial. And we have trials which show benefit in patients with established heart failure. So we have now treatments for prevention of heart failure and trials for treatment of established heart failure, as shown in the DAPA-HF, EMPEROR, REDUCED, and very lately the SOLOIST worsening heart failure trial. The DAPA-CARE is the largest sodium glucose transporter inhibitor clinical development program. We have already the DECLARE trial, which showed prevention of heart failure in diabetic patients at high risk. We have the DAPA-HF and the CKD DAPA trial, which showed significant improvement in kidney function by using dapagliflozin. So now we are moving from prevention to treatment and from diabetes to no diabetes. Thank you for your attention.
Mahmoud, thank you very much for this nice lecture, but can I speculate or give you the question? The next step of SGL2, your last slide has shown us in heart failure and CKD, diabetes. So my expectation that the next step for the SGLT coming from the previous drugs will be post-MI. What do you think? Because the mechanism of action suggested will be the which is eNOS improvement, the endothelial function and remodeling. So do you share me this expectation?
Yes,
that
absolutely, I agree. I totally agree with you. And there are ongoing trials using sodium glucose transporter inhibitors in patients following myocardial infarction. These are trials that are ongoing, and we are expecting the results within the next 2 years.
So from your point of view or from your mind, at which day? Second day, the same day of infarction, or after 1 week? What do you suggest? Because if we are going to implement this before the guidelines before, what would you think? The next day, the same day, or
Yes,
after
okay.
1 week?
Answer, Mahmoud. I think this is just in the AHA trial regarding the EMPA in left ventricular remodeling. These start as early as possible, like the ACE inhibitor. You give the ACE inhibitor from day 1. But yes, from day 1. They started this with improvement of the left ventricular volume. So I think most of GLE2 is taken as early as possible in order to prevent left ventricular remodeling.
So day
Well,
one,
I have an answer to this question, if you allow me, please.
Yes, Mahmoud.
We had recently the SOLOIST trial from in the...
محمود ممكن نعلي صوتك شوية؟
we have an answer for this question It was the Solace trial, which was declared in the last American Heart Failure Association meeting. Sotigliflozin was used, which is sodium glucose 1 and 2 transport inhibitors, which was used shortly after stabilization of acute myocardial infarction, heart failure, in hospital or shortly after hospital discharge, and the results were positive or quite positive. So in this trial, sotigliflozin was used very shortly after acute myocardial infarction in patients who were just stabilized from acute decompensated heart failure. So I think we can use these agents very early in the course of heart failure.
Dr. Yasser Hussain.
Okay, thank you, Professor Mahmoud. I think the crucial issue in implementing the DAPA post-MI as fast as possible, that even the diuretic effect is not accompanied with a neurohormonal activation, which is very hazardous in this critical period of time.
I totally agree with you. There is no hypovolemia.
Professor Mahmoud Hassanein, you hear me well? Okay.
Yes, I do.
أنا محمد النعماني Professor Mahmoud Hassanein. أولاً many thanks for your elegant and very illustrative presentation as usual. Actually, I have one comment and one question. Actually, in the last session, Professor Sobhi has highlighted a very important topic, which is the indicative power or significant power of ejection fraction in the expression of the improvement. I think this is a bit just a deceiving number, especially when we are talking about heart failure with mid-range and preserved ejection fraction, because the problem here is not ejection fraction. So we have to validate new parameters to judge the improvement of the patient, not from the subjective aspect, comparing the baseline before the treatment with the follow-up visits. I think we have to rely on filling pressures parameters like E over E dash and the global longitudinal strain. Most recently, even the conventional echo machines correlates between global longitudinal strain and ejection fraction in the same machine. It gives me the reading instantly with ejection fraction. I think this is the future for judgment of remodeling, especially all the well-settled drugs in heart failure like ARNI, beta blockers, the CRT. They are now speaking about reversal of remodeling because our patient is, after improvement of symptomatology, he is eager to know that his cardiac muscle is improving. This is my comment. My question for you, in non-diabetic patients, would you have any experience about higher doses better for the patient like ARNI or beta blockers or statins in our cardiovascular patients? Higher doses of SGLT2 inhibitors will be beneficial. Higher is better.
Well,
and what is the future of this group after soloist heart failure and scored in heart failure with preserved ejection fraction? This is my question for you.
Yes, thank you for this question. You know, in the DAPA-HF and the EMPEROR reduced, there was no difference between the doses used, whether it was 10 milligrams or 25 milligrams. The same effect, the same beneficial effect was accrued whether you use the smaller dose or the higher dose. So I don't think a higher dose would be more beneficial except for perhaps for hyperglycemia.
Thank you very much, Dr. Mahmoud. I hope you enjoy and see you in Alexandria as soon as possible.
Thank you.
Okay.
Shukran.
You will be with us till the end, Mahmoud, because you have a closing remark.